I'm here with Dr. Rebecca Cohen, who is a holistic women's healthcare physician specializing in pelvic well-being throughout all of women's lives. Hi, Rebecca.
Hi, Emily. It's so nice to see you.
So nice to see you too. I'm so happy that you're here. Thank you for taking the time out of your busy schedule to do this. Can you tell me, share with me your background and your journey and your evolution to where you are now?
Sure. So I have been interested in birth since I was a teenager, and initially went and did midwifery training right out of college. I worked at a birth center and was trained as a midwife there, and then ultimately got into medical school. And I really had a hard decision about whether to continue midwifery or whether to go into medical school. But my midwifery was not legal in the state at the time. There was also a midwife in our state who had been turned into the nursing board for practicing medicine without a license. And I thought, well, I'll be a physician and I'll just do it a different way. And then when I went to medical school, I did finished medical school. In medical school, the OB that I saw there, I knew I didn't want to be an OBGYN. And so to do obstetrics, I did a family medicine residency first, and then I did what's called an operative and high risk obstetrics for family medicine, so that I did C-sections and all of that. And so I ended up coming out of my training. I had a practice where I worked as a nurse with a nurse midwife in the hospital. I was kind of considered, the doctor you would go to if you wanted natural birth. But what I didn't realize is what I thought was natural birth, or when I thought I was pushing the envelope and out on the edge, really was never physiologic birth and really was never natural birth. And then I had 5 kids in 8 years, and I adopted 4 more. So I stepped away from birth work. And as my kids got older, looking to return to birth work, I started sort of my studies fresh and new, even though I've already delivered, thousands of babies before. And so I went to the Freebirth Society's Radical Birth Keeping School. I'm in WAPIO's Matrona training, and have my own home birth practice outside of the hospital. And it looks very different. I always thought I would do home birth, and I did support some home births and do some home births, mostly friends of mine, back when I was a doctor in the hospital. But I always had this vision of what needed to come with me, or what my supply bags would look like, and basically what I was thinking that it would look like, now I realize, was really medicalizing birth in the home. And really from my midwifery training, even all the way back before medical school, it was a very medicalized midwifery training. And so how I envisioned the way I would practice home birth one day and how I'm actually doing it right now is very different.
Thank you for sharing all of that. I read some things on your website, and you said that you were the obstetrician who rejected the misogyny of traditional OBGYN residency, who went rogue while being married to a family of doctors. Can you elaborate more on that?
Yes. So I met and fell in love with my husband during medical school. And my husband has 3 brothers who are physicians, and his dad's a physician. And his dad was a family physician who did obstetrics, practiced obstetrics. He actually stopped in the 70s, in the early 70s. I think it's interesting because he delivered, as well as full-scale family practice, he delivered over 200 babies a year himself. He did breeches and all these things that now no one does anymore, because that's what family practice docs did. And so it always felt I didn't really talk about my midwifery background much to them at all. And it's not like they would have been too judgmental, but I just didn't talk about it with anybody. I didn't really talk about it during my training. I was careful. I really kept my cards close to my chest, and was careful with what I did so as to sort of fit in and get through my training without ruffling any feathers, with the thought being, okay, one day I'm going to do it differently. One day I'm going to do it differently. And what I didn't really realize, and that now that I stepped away from birth work when my kids were young to do office work. And then as I'm coming back to it now, thank goodness for that break. I think if I never would have had that break, I never would have like quite seen the difference to what, because I was on the far edge of what, being a liberal or a natural supporting doctor did. I mean, people thought, the nurse, I would let my ladies stand up next to the bed to give birth and things like that, or labor in the tub, some, and a lot of that's gotten more common over the years. But the fact is that's not physiologic still. It's not natural birth still. And I thought that I was being supportive when really, this is what Emily Saldea said when I talked with her. She's like, you were just being humane. You were just being humane, but it wasn't like truly supporting natural birth. But so I didn't really talk about it a lot. And once my husband's family is actually really supportive, and I'm grateful for that, because I did have my babies at home, some of them, and they never said a peep. They never said a peep. But I didn't really tell them I was having my baby at home. You know what I mean? We didn't really discuss it. But thankfully they didn't. They let us be. And no, I don't know what their feelings are on it. Maybe they're perfectly. We just haven't discussed it still. 20 years later, and so yeah.
Your first birth was a planned home birth that ended up transferring to the hospital. Can you share the effects or consequences of that hospital birth?
Yes. I've been thinking a lot as I returned, over these last couple of years into birth work, and really seeing that birth with new eyes. I had a nurse midwife who delivered both in the hospital and at home with me, and my son was, and I dearly love her. I dearly love. So my son was posterior. He was big. He was 9 pounds, 12 ounces. He was big. But it started out with intervention right away, right? And so I was coming up on 42 weeks, and I was not allowed to deliver outside the hospital after 42 weeks. Furthermore, because of my medical training, I thought I had to still be in the hospital at 42 weeks. It never occurred to me that it was okay, even though my mom told me that she went to 43 and 44 weeks, like back in the 60s, like she did. But it's still, I was like, oh no, 42 weeks. So it started with, oh, that's coming up in 3 days. Let's strip your membranes and take castor oil to see if we can't give you that home birth you wanted, right? And so as I ponder that now, I feel like I was put into labor too early when he was in that posterior position. And that if given more time, he could have rotated around and dropped in easier. But instead, I was having, diarrhea from the castor oil and long, late nights. I went into labor on a Friday night, labored all Friday, all day Saturday. Ultimately transferred into the hospital Saturday evening, and then all through the night Saturday night, and he wasn't born until Sunday, which really isn't necessarily that long of a labor for the first time mom. And I kept feeling like I was lucky. I kept feeling like, well, I was lucky. I was lucky that I had found somebody willing to be with me at home. I was lucky that she was helping me out with being there. I had meconium, and we were supposed to transfer. I didn't have meconium. Joseph had meconium, but where he had pooped in the waters, we were supposed to transfer after that, and she let it slide with my husband and I. So there were some out. So I kept feeling like I was getting lucky and having this extra. And then we went into the hospital, and then it was the full range of everything that happens to you in the hospital. You know, my waters had been broken so long, so they wanted to do antibiotics and start with some Pitocin, and then with the Pitocin and the exhaustion, I went for the epidural, and it was just one intervention after another. So I actually ended up having what I realized later was PTSD from that birth, and I went and got EMDR to do some trauma work around that birth. I couldn't look at the photos. Like, I had photos of myself in the bed with him with the IV poles and all of that, and I would like cut them out of the photos. It was a typical, I don't know what to say about it other than it was a typical hospital birth. Like, my midwife was with me for a while, but ultimately the OB came in because I had been in there for so long, and he said that he was going to he said it had been so long that he was going to go wash up and put on his scrubs, because he came in his Sunday morning clothes initially. He was going to go wash up, put on scrubs, and then come back to do either vacuum or forceps. And at that point in time, I was like, you know, I was just pushing whether I had a contraction or not to get that baby out before he came back. My cervix ripped, and of course, my perineum ripped and down through my rectum. So there were a lot of consequences of that birth. And knowing what I know now, that I could have potentially just waited, and then he would have come out, you know, potentially fine at home, or even with the transfer. With the transfer, I felt like she had already given me so much. She had already been letting me stay at home with meconium for so long that, yeah, enough was enough. It was time to transfer. She was nervous. We were nervous. The baby still wasn't coming. And that's the other thing. I think we could have just stayed at home despite the meconium as well, if I would have had the support of somebody who was really willing to stay in there with me. And I think he could have been born at home, even despite like going into being forced into labor early and all of that with the castor oil. I mean, I know that now. And so, you know, it's hard. It's hard looking back on it. And I think there was a study. I was like, oh, it's in the perfect timing for this podcast. So there was a Cochrane review that just came out. Did you see? Yeah, did you see that? It's great.
Yeah, I saw it.
Yeah. So the Cochrane review is sort of the gold standard with medical research, right? And so there's all different types of research studies. And this is why it's so confusing for women when they get on the internet, because you'll have an article written about one study, and it may not be a good study. It may not be validated. There may be, reasons that study was flawed. But somebody will take that and then write a headline or write a blog post. There was just like an NPR study a couple years ago. Oh, home birth is not, home birth can be great, but is it really as safe as people think? You know, and so then you start, that's like the first one. If you search safety of home birth, that'll pop up, you know, and then you'll have others that have this other study in the North American or the Midwives Alliance in North America. MANA did a really big study showing that it was safe in North America. That was a good one because we had seen it was safe in other places of the world. So there's others quoting this study or that study or whatnot. But the Cochrane database is not just for birth or birth related things, it's for all medical things. And why the Cochrane database is so strong is because it's a review. So they look at all articles from all around the world, and then they go through and rank those articles to see how good are they truly scientifically, and then they put it all together and do what's called a meta-analysis, right? And so the Cochrane Review had written one in the past. I think it was like 2009. I don't know. It's like 2009, something like that. And then again on home births, they had written a couple on home births in the past. It might have been like 98 and 2009 or 2012 or something. They'd written a couple. They just re-looked at all the data that had come out since then. And what the upshot of that Cochrane review is that the questioning, do hospital births do more harm than good? And so everyone always asks, is home birth safe? Is home birth safe? And what they aren't asking is hospital birth harmful? And so, yeah, I pulled it up just to mention because it's fresh. It's fresh off it just came out March 8th in 2023. These were the author's conclusions. The review shows that for selective low-risk pregnant women, the evidence from randomized trials to support the planned hospital birth reduces maternal or perinatal mortality, morbidity, or other critical outcome is uncertain. In other words, it's saying to go to the hospital and that it makes things safer, that's uncertain. We can't say that anymore. It says the quality of evidence in favor of home birth from studies seems to be steadily increasing. And it's just as important to prepare a regularly updated systemic review. And so some of the specifics out of that article showed that planned hospital births increase the number of complications and interventions without achieving any demonstrable benefit in terms of lower maternal or child mortality, i.e., it's not safe. They don't make it any safer, but the risk of major bleeding in hospital is increased by 50%. The risk of infections afterwards is increased by 50%. The risks of various interventions during childbirth are also increased. So obviously, if you're having it in the hospital, your electronic fetal monitoring risk is increased, anesthesia, episiotomy, and all that. The risk of having a cesarean is 20% higher. For the babies, the risk of having the electrodes screwed into the scalp, twice as high. For the children of second-time mothers, the risk of being admitted to the neonatal unit is increased by 20%. So it's actually more risky. Everyone always says, is it safe to have it at home? Isn't that risky? And so this is sort of when the gold standard Cochrane review comes out and says, ooh, in fact, it might be more risky at the hospital, and we need to keep looking at this data as it comes up. Another huge one with regards to both the baby and the mama, the difficulties establishing breastfeeding is increased by more than 50% for those who give birth in a hospital. And yeah, all of those. And so it was great to see it. I didn't even know it was coming, and it hit, and a colleague sent it. And then once the colleague sent it, but then I started seeing it everywhere. And I'm so glad it's out there because when I was in medical school and we were looking at, it didn't matter what we were looking at. We were looking at cholesterol lowering drugs for the risk of heart attacks later. And there would be all these different studies. Well, what does the Cochrane review say? Has Cochrane reviewed it? Has Cochrane looked at it? Because they are so strong in their data analysis. And so for them to come out with this on home birth, and I haven't gone back, I'm curious to go back to read those earlier too, to see what they said then. But I'm also encouraged by the fact that there's more data out there that they were able to include, and the fact that they said, we need to look at this. We need to look at this regularly because, it might not be as safe. It might not be as safe to be in the hospital, but what was shocking was it might actually be more risky is what they're saying.
Yeah.
Which a lot of us just sort of practically know. Yeah. But it is a big deal to see sort of the big guys come out and say that.
Yeah, that is wonderful news. Yeah, I'm definitely going to I'll put a link in the description of that review. And I've heard so many stories of women who've had their births, medical interventions, and the impact it has postpartum from latching and breastfeeding. Like what are your thoughts on that and the why?
Yeah. So many things. So first of all, we know that Pitocin, so there's natural, and this is Sarah Buckley's work, which is really great to look at. We know that oxytocin in our body is the love hormone, right? It's the bonding hormone. It's also the hormone that causes uterine contractions in labor. And if we look at oxytocin release, it increases, when we start labor, but there's also a huge oxytocin release postpartum and right as we're giving birth, really at birth, at the moment of birth, there's this big oxytocin release. That oxytocin release helps with the bonding. And if you are giving synthetic Pitocin, which is it binds to the oxytocin receptors, right? Because it looks like, but it doesn't give all of the benefits that oxytocin does. It's like super high dose specifically for the uterine contractions. And so a lot of times people won't even realize that they had been given Pitocin because they didn't get it during labor. They know about it during labor. Maybe they had a natural labor. Maybe they were allowed to do intermittent monitoring and all that. But in many, many hospitals, it's standard of care that when you give that IV bag following birth, you push in 20 units of Pitocin in that IV bag because it decreases hemorrhage. Probably does decrease hemorrhage if every single person got it, but to what end? And the to what end is that it definitely disrupts breastfeeding and successful breastfeeding at 1 month out. And that was Sarah Buckley's work, where she looked at breastfeeding 1 month out. Was just that one study, but that's one example. The other thing is I do a lot of so what I did before I returned to birth work is really work with anything that a woman would come to see an OBGYN for but didn't want to use pharmaceuticals or surgery. So like I was kind of the person that either people had been to physicians and been like, I don't want that, is there something else, and come and find me, or people who were never going to go to the physicians in the first place unless it's their last resort sort of found me first. Those are the two types of women kind of to come and see me. And so I have been working with women all this time with pelvic floor issues. Maybe they were told they needed to have pelvic floor surgery, or maybe they were told that they needed to have further surgery or go see or have more procedures or take a medicine so they don't pee on themselves as often. If they have the titchy bladder, it's called, or urinary urgency. There's two different types of bladder leakage. So one's what's called stress incontinence and the other is urge incontinence. But they're coming to me for these things. And so I've been working with pelvic floor health for years and years. And with my postpartum moms coming to see me for pelvic floor health, while I'm working with them with their pelvic floor, oftentimes they were telling me stories of their birth and how difficult their birth was. How many times, how many women have I sat with? I was planning, I thought, I had my doula with me. I was planning on having this natural birth in the hospital, but I ended up with the C-section, or I was planning on a home birth, but then my midwife said I risked out. So then I went to the hospital and got induced, or all of this. And it was only until recently that I heard of this concept of birth trauma debrief or birth trauma healing sessions, or all of these. And when I looked it up, I found that people are doing that all around. So many people offer it. And then I realized, wait, that's what I'm doing when I'm sitting with these postpartum women and they're telling me their stories and their heartbreak. And we're talking through it. We're talking through, well, how did this lead to this, to this, to this? And then they wonder, did that really have to happen? Did I really have preeclampsia? Someone just told me that this week. Did I really have preeclampsia? Because my blood pressure never got higher than 135/85. And they never did a 24-hour urine or whatever. Like, these are the kind of things that came up with me to me, even though I wasn't taking care of them technically prenatally or technically immediately postpartum or anything like that. And I'm like, wow, there's a whole lot of hurt. There's a whole lot of hurt for the mother and the baby, obviously, and a whole lot of trauma. And the word is trauma. And so even though I just read off all these great things that the study showed, not great, actually horrifying things, right? That this study showed. This study doesn't talk about the emotional and psychological, the trauma that occurs with the mom. That's not in any of this. They can measure how many times is this intervention done and this intervention done? But it doesn't measure that. And so for me, I realized, wait, I'm already doing this birth trauma debrief thing with women all the time without calling it that, because they needed somebody to talk to and somebody to tell their story to.
So would you confirm that from, some women who've had problems with their babies not latching and breastfeeding, it is due to some kind of trauma from their birth?
Oh, absolutely. Absolutely can be. And it may not be that every time, but does a traumatic birth set you up for breastfeeding challenges? Yes. Yes, it does. Does receiving artificial Pitocin before, or Pitocin is artificial oxytocin, during labor or after birth affect? Well, we know that now. That's studied. So that's another factor. Doesn't mean if you get Pitocin that you're definitely going to have breastfeeding troubles, or that you're definitely no, but it's certainly common. And can working through the healing of that trauma improve the breastfeeding relationship with your child? Yes. I've seen it personally many times in my office. So yeah, even in my own work. Yeah.
Can we get into a woman having a home birth with a licensed professional versus a home birth with an unlicensed midwife, a birth keeper, a traditional birth attendant? So if there was a first-time mom wondering about that, what would you tell her?
I think part of this has to go back to the discussion of risk, which I kind of bring up again and again. It always seems to come up in every podcast I'm in, is that we can talk about what risks are. We can talk, now we have these stats to back up the risk of sort of what your increased risks if you have a hospital birth versus a planned home birth. And then there's risks of staying at home in some situation. There's all of that, but then there's absolute risk and relative risk and all of these definitions and how you look at risk. But really, it's up to the mother. It's all personal. Risk is a personal choice. So what may be risky for me may not be what's risky for you. And when you look at the success of physiologic undisturbed birth, one of the biggest factors is safety and feeling safe with your provider. And so if you have a provider that isn't feeling safe, or that has protocols that they have to adhere to, because otherwise they have their license, and their license going to be at risk, like my beloved midwife, who was not allowed to deliver babies outside the hospital after 42 weeks. So she was going to help me by doing these interventive things to get me moving along. So she kind of had two masters. She had her license, which said, even if her personal beliefs were, I think you can go past 42 weeks and be okay, but she had her license, which said, I'm not allowed to take care of someone outside of the hospital at a home birth past 42 weeks. And then she had me. And sometimes licensed midwives are in that quandary. Whereas unlicensed or authentic midwives or birth keepers or traditional birth attendants are not. And they can fully give themselves to the mother, to support the mother. But ultimately, it's the mother to decide, what risk am I comfortable with all of this out there? And it can be, overwhelming. But where do I feel most safe? And what's going to set me best up for success? And who am I going to have that's going to support me and be with me for this time and help me feel safe? Because feeling safe is what allows your baby to come through undisturbed. And so, for one woman, that may be having no one there and doing free birth, and that's what really helps her feel. And for another woman, that may seem too risky. And so, and another, there's many women who feel more comfortable in the hospital most of the women I work with go running the other direction and not feel that way. But yeah, I guess, did that answer those are just
Yeah.
some thoughts on it. Yeah.
Yeah, that's helpful. So what for a first-time mom who really does want a home birth,
Mm-hmm.
but is scared, has fears and concerns, and they are thinking about hiring a midwife or birth keeper, if they were to meet a licensed midwife professional provider, what questions should they ask them to know the page that they're on?
Yeah, I think some of the questions are what are the circumstances that you can no longer serve me at home? And those laws vary from state to state. So it really varies. And some actually, where we are in Kentucky, has some of the freest, openest laws. They in Kentucky, you have to get an informed consent. I think an informed consent sign. Hopefully, I'm saying this right, but I believe it's like an informed consent signed saying that they understand that it's risky or something. But then at that point, they're not bound. Whereas some states, it's like 42 weeks this, and there's different states, and I've heard so many different stories from different places. I know for a long time in Arizona, and I don't know if it's still true, but you had to have a manual exam at home every certain number of hours in order to be a licensed midwife at home. You had to do that. And so I don't know if it's still that way, but so that's the kind of questions I would want to know. Like, what are your regulations, and how do you feel if I go outside those regulations? What's going to happen? Because I think what happens, I know what happens, is a lot of women, the midwife says, I support natural birth, and they do, I think want to support natural birth, right? And then if we take 42 weeks again, you get up to 42 weeks and the midwife feels like their hands tied. But also, if you look back to my birth story that I started with, I didn't know the difference either. Like I was an OB at that time, and I thought, okay, 42 weeks, I'm done. I thought I was doing the safest, most correct thing. Now you look at it, the evidence is not there, by the way. But which really started this cascade of interventions in my son's birth. And so, and I think what's challenging is that moms have to take the responsibility themselves. And if you don't want to take the responsibility yourself to look into this and make the decisions yourselves, then you're putting it in someone else's hands, whether it's the doctor at the hospital or whether it's the midwife. And so developing that trust is important. Once you've kind of signed on and she's your provider, then hopefully you have all these conversations, ask all of the conversations. I think the one question is, at what point do you not feel comfortable? And then realizing as a mom, you have a choice. You have a choice to say yes or no. But if you've been planning for the last 6 months to work with this lovely midwife that you adore, and it seems great, and then she gets to the end and she's like, I'm sorry, your blood pressure reached this point on this day, I can no longer take you. That's rough and scary. And so what's a mom to do? That's the majority of questions that we get. That's a lot of times I'm questioning my moms what to do at this point. And it's a big leap for a mom who hasn't thought about it at that point to suddenly think, well, I'm just going to stay at home and have it by myself since my provider can't take care of me anymore. That's a huge, huge leap, because really there's a lot of prep, right, that needs to come into that beforehand. Yeah.
Absolutely. A lot of women messaging me and asking about their fears and concerns. And the number one question I do get is, I want to have a home birth, but what about postpartum hemorrhage?
Mm-hmm.
Can you talk about that and the likelihood and why it happens or why it wouldn't happen at home? What causes it?
Yeah, postpartum hemorrhage is a big, big fear that comes up too. For me, that's probably the biggest question I get asked too, for sure, is postpartum hemorrhage. The question of how often does it happen is we don't really know. There's not a lot of evidence out there about truly undisturbed physiologic births. And there's no evidence out there on free birthers, especially planned free birth. That was always the trouble with midwifery statistics when they looked at out-of-hospital births, is they combined the planned out-of-hospital births with all out-of-hospital births and mashed all of those in there. And that includes people who might be drug abusers, frankly, and never get prenatal care and then have their drug addicted baby at home while they were high, or someone who had their car on the side of the road while they were, had their baby in the car on the side of the road when they were going to the hospital, and that's where they had their baby. And so for a long time, those statistics were mashed in, and that needed to be pulled out and looked at planned home birth. And that's what that big MANA study, or Midwives Alliance, was like, actually for the first time extracting that and looking at planned home birth or out of hospital birth. There's nothing on free birthers, and so we don't know. I don't know how often postpartum hemorrhage happens. I do know when intervention is done, when Pitocin is done, when women are induced before that natural hormonal cascade that usually happens and supports their bodies during labor, and that's interrupted, that the postpartum hemorrhage rates are higher. And so it's really hard sometimes for women to know how much blood is too much blood, and am I losing too much blood? And that does seem to be a big fear. There's also things that can be done with self-massaging the uterus and supportive care for that. I think especially for a first-time mom, birth's bloody. If you look at any of those, now we get to see the photos. Those photos weren't there even just a few years ago. People are free birthing and posting on social media, and the moms are covered in blood and the babies are covered in blood. So there's a lot of blood there. So how much is that, and what's really normal blood loss? Same thing in the birthing tubs. So if somebody births in water, and whether it's their bathtub or a birthing pool or wherever, a little bit of blood can be spread a long way. It's hard to tell how much is too much. So that's a challenge. What I usually tell women is, if you're bleeding so much that it looks like a hose coming out, you call the ambulance and go. I don't know. It's pretty obvious if you're flowing like that. And those type of hemorrhages, even in the hospital, are really, really rare. The definition of postpartum hemorrhage, and if you look at statistics of postpartum hemorrhage, it's been greater than 500 cc of blood loss following delivery. Now, that can take place that they have a bunch right at delivery, and then there's sort of a heavy bleeder over the next few hours, and then it stops. The placenta can come up part way before it comes all the way up. So right after delivery, they can have several big clots. I was definitely taught in midwifery school as well as medical school, to measure the clots and estimate. If it's a clot this much, it's 100 cc's. And if it's a clot this much, it's 200 cc's, and how to look at the pad. So for one thing, it's estimation. It's people looking at the blood, estimating, and deciding whether they're going to call it what they mark down the blood loss. Am I going to call it 600 because, man, that was a lot? Or am I going to call it 200 to 300 because that's normal, or there was hardly any, so we'll call it 2? Like that quantitative, there have been very few studies, there's some, of truly like measuring the pads and true like quantitative getting of what's a hemorrhage. Other than that, if any physician or anybody puts down, any birth attendant, of how much blood is there on the pad, and they decide that it's clocked at 500 or more, that's postpartum hemorrhage. That's counted as postpartum hemorrhage. And that's not something a mom's going to know. So there's, that's never seen it before. Even a young midwife doesn't necessarily know it at the beginning who's done. So you just sort of get a sense over time. The other thing is, and this is another one I talk with, because I just recently had a home birth woman who asked me the same thing, because this comes up so much. Our hemoglobin levels, or how much blood we're carrying, if you will, if you can go into labor at a 10, or you can go into labor at a 13. And if you lose so much blood that it's going to knock you down 3, if you're at a 10 going to a 7, or a 9 going to a 6, you're not going to feel well. You're going to be weak for a long time afterwards. If you're at a 13 going down to a 10, then even though you had this big amount of blood loss, even though if you technically hemorrhaged and you're above 500 for how much you lost over your postpartum time, you're going to be better off than a mom who came. So nutrition is huge, and really eating good and well. And I spend so much time with my moms on nutrition and what that really means. Because that alone helps, because you can imagine that, right? So a mom who already has low blood levels that's dropping down versus one that's up here dropping down, that and the true postpartum hemorrhage where there's just like blood flowing and flowing, that's incredibly rare. Even in the hospital, most of the hemorrhage statistics are from like adding up, oh, it's a couple hours of birth and we went back and there's another huge clot, so that's another 100. And so the overall, it gets added. Does that make sense?
Yeah, that absolutely makes sense. Can you elaborate on the beauty of a woman's body and their hormonal blueprint of physiological birth, and kind of, touch on another question I get from moms where I share that I free birth. They ask, wasn't it painful? And these are women who may not have experienced physiological birth. So even, touch on the endorphins that occur. But yeah, if we could start from the beginning, when baby shows signs of readiness, to let mom know that I'm ready to come out.
Yeah. So first of all, we don't know why. We don't know if any of us had that figured out, like how to really put women in labor, what that hormonal cascade was, that would be a huge cash cow, right? Because even when we induce in the hospital, it's not great. It's really like blunt. Pitocin is this blunt instrument. It's this one hormone that we're given in super high doses, and it doesn't even act exactly how it does. And we're giving it in this artificial way. And so it was only Pitocin induction for a long time. And then we figured out about the prostaglandins, right? And so that's where these medicines called like Cytotec or Cervidil came in. Oh, we need that first to soften the cervix. So we need to get that on board too in order for the Pitocin to work. Well, that like that helped with inductions is what I was like, well, that helped, but I'm like, it actually hurt women because it made induction at one point in time when all we had was Pitocin. If you look back in the past like 40 years or so, the C-section rates were so high because inductions were not, and so people held off inductions. But then when inductions got easier, because now you can add Cervidil or Cytotec in the mix at first and get it all softened, and then it works better. Or and then they came out with Foley balloon and all of these other things. Foley balloon, right? That's just like physically pushing up a balloon and taping it to your leg. This is not sophisticated, right? This is blowing up a balloon, having it pull on the cervix from the inside, which is not even how when the fibers of the uterus dilate and the cervix dilates, it's like brute force in there, right? And so these are the ways that we induce women. We don't have it figured out at all. The hormonal cascade, we don't completely have figured out. We have ideas about how it works, and we don't know why women go into labor when they do. We don't know why. And so there's been a lot of studies looking to try to figure it out, because that actually would be a great cash cow. If you could figure that out and then you could make the product that did that, you would be a bajillionaire, right? In modern obstetrics, right? That would be the jackpot of trying to figure that out. At some point in time, the baby and the mother, both of them, the mama baby dyad, some hormonal or what communication takes place that it's time. And then all sorts of things happen throughout the body. There are these receptors in the uterus that act as, we just learned about this in WAPIO, but in one of her recent lectures about how just like our heart has pacemakers, our uterus has pacemakers, and those pacemakers, to begin those waves, to begin those contractions, listen to oxytocin. And when the false oxytocin or the Pitocin comes, it can set up ineffectual contractions or hit just those two too hard rather than the other pacemakers. There is the not just estrogen and progesterone and oxytocin, which we've talked to so much, but the endorphins or the feel-good hormones, the adrenaline, and that sort of adrenaline rush. And people know, whether they've had a baby or not, people know what adrenaline rush are. Adrenaline feels good. If you exercise hard, you get an adrenaline rush. That's why people exercise, because it feels great afterwards. If something exciting happens, even if it's you're walking up on stage getting your high school diploma, you feel good afterwards, right? Everybody's throwing their thing up. Everybody feels good. You're getting your picture taken. It feels good. Anything like that, that's always your adrenaline. Those are those catecholamines, and those come on board during labor. If you're laying in the hospital bed getting, the adrenaline does not come on board if compared to if you're undisturbed, right? For sure.
Mm-hmm.
And the other thing as well is cortisol, or your stress hormones, and how those come into play. There's been a lot of study about cortisol and whether or not cortisol leads to, but there seems to be a cortisol burst, or usually when we hear cortisol nowadays, people think about high cortisol being bad because it's the stress hormone, bad all the time. But cortisol actually goes up as you go into labor, and that's actually a good thing, that you're boosting up to.
Yeah, good stress.
Yeah, good stress. I mean, there's so many things possible that we don't see. We don't see in the narrative pain-free childbirth. Like, does that really exist? How many times? I mean, there's just so many examples of people, whether they're like running on the beach and having a great time and laughing and playing, and then they've stepped on a shell that's cut their foot, but they don't realize until half an hour later, 15 minutes later, that their foot's cut and bleeding. No idea, because they were out playing beach volleyball and having a blast. You don't feel it. Whereas if you were sad and you were stressed and you were taking a beach walk and you stepped on that, you would feel it right away. You would know it. But that adrenaline of your beach volleyball game, if I'm going to give this, I don't know why this example popped into my head, but like, you don't feel it. So there are other examples that maybe make that more real for people when they say, how can that be possible? Well, have you ever been really excited and accidentally had an injury like that you're rushed through? You don't realize until it's done. Certainly that happens with things like accidents and things all the time, where people have an accident. My daughter recently had a bike accident. She got all the way home before she even realized that she was bleeding and hurting, because it was just so much. She dumped her bike. She's a teenager, and then came home and then didn't hit her till she got home. That happens during labor a lot. And so the other, pushing, and the fact, I would say that concept that there's really a disservice to this stages of birth, that you're going to dilate and it's going to feel this way, and then you're going to have pushing and it's going to feel this way, because so many women, their babies slip out, and you think, how is that possible that your babies slip out, or that you didn't have to push your baby out? But that's a common story that happens all the time. And when birth is left to be undisturbed, the way that cervix, peels back, and then the way that baby moves down in the canal, and then the way those hormones hit your uterus and the uterus contractions work differently to then expel your baby, it is possible. It's possible to have your baby slip out. It's possible to have them hurt but not be painful, or for there to be pain but not suffering, if that makes sense. Yeah,
and it's possible that women don't even have to push their baby out.
That's right. That their babies just emerge, not all the time, and not every woman, but certainly there's many women who have had that experience, where their babies just emerge when left undisturbed.
Yeah. Oh, I know we have a few more minutes. I was wondering if we could answer some questions that some women on Instagram wanted to ask you.
Sure.
So this is from the.sovereign.rose. She asked how to successfully have a first home birth after previous losses.
Yeah. I don't know whether Yeah, I don't know what losses necessarily refers to, whether that's loss of a child during childbirth or loss of multiple miscarriages or whatnot. But I think that that's the time to go deep. And if you decide to have someone there with you, really going deep with whoever's there, whether it's your partner, your care provider, all of that, and do that excavation and that deep work prior so that you're not blindsided in labor with some of that and with some of the things that can come up. And how you do it is you just do it. Women do it all the time, and welcome that as part of, you're not, it's not separated. It's not my losses were here and then my birth with my new baby's here. It's really all the same. And so your birth with your new baby is connected to your losses, and it will be present with you. It will be there with you. And that's why I talked about sort of excavating and figuring out what is it that I'm walking with. And the opportunity for healing will be there as well. There'll be both grief and great healing. All the potentials there, all the same. So
Thank you. And this one is from Alexa Debner. Your thoughts on SUA, which is single umbilical artery. Would you still do a home birth or be monitored at the doctor?
So I'm going to go back to risk about this. So what my suggestion for anyone who has a specific question like this is to look, find out about it, ask, and use this before, like ask as many people as you can, which I guess, she's asking me, but ask a doctor, ask another doctor, read about it yourself a little bit without rabbit holing too deep about it. Ask a neonatologist, they take care of babies, or ask a baby doctor, and then see what you can find as the risk, and then hold that risk yourself and say, what's my personal relationship to this risk? Do I feel like that this means that I need to be in the hospital or not? I also tell people a lot, ask your loved ones and the people that who do you check in with? Like, who's your good friends? Who's your beloved husband? Ask them to go over and help you with that. And whether it's a single umbilical artery or whether it's, I had preeclampsia, because that could be a billion things. It could be, I had preeclampsia with the last delivery. Does that make it too risky for me? They only found, one. Does that make it too risky for me? But in particular with specific single umbilical artery, the single umbilical artery can be, they know that because she's had an ultrasound. Otherwise, they wouldn't know that the baby has had a single umbilical artery. And if it's an isolated thing, so sometimes single umbilical arteries are seen in babies that have other defects, if you will, whether it's heart defects or other defects. I hate the word defect, but that's my medical term, right? And so it could be a marker for another, for that there's something wrong with the baby. Let me say it. And sometimes babies are just born with them and it's nothing other than that. If they've had a good look on the ultrasound and they don't see anything, because she didn't ask the question, what about a baby with a single umbilical artery and a heart murmur that they saw an echocardiogram, or what if, because usually if they see them, they also do an echocardiogram on the baby, or what if this and this and this. And so those are different categories. Those are all different things. So an isolated single umbilical artery can be an isolated finding, or it can be a marker of something different. And so finding out how often it is one or the other. And then, like I said, talking with your trusted people, getting your books down, even if they're people looking at them, taking that to heart, or saying no and putting it back up on the shelf.
That's great advice. Okay, one last one really quick. This is from Anjali Artham. She asked, she's 43. She's had 2 C-sections, a tummy tuck. She wants to have another baby. Any concerns you see?
No, if you it's the same. No, like if we had, if our bodies are we get pregnant, our bodies are saying yes. And so that they're ready. We got pregnant, and so from there, then it's all those other things that I just said, your own comfort with risk. What it means, a lot of women are fine having, whether it's vaginal birth after 2 cesareans or home birth or unassisted birth, and others are not at all and just want to sign themselves up for the 3rd cesarean. And I can't answer that question for her.
Yeah. Okay. Thank you so much, Rebecca. You're a wealth of knowledge. So I appreciate you taking the time to do this.
Yeah, take care. No problem.